All right. Yes, I will call the Medicaid Oversight and Advisory Board back to order after that interruption. And I appreciate you all being back at the table. And I would actually request maybe if we could expedite your all's testimony a little bit because of that interruption. As you know, we have a hard stop at 10:45, and so I just want to make sure that we have time for questions and we have time for our next presentation. So, and I apologize for that. I had no idea that was going to happen, but if you don't mind being a little bit more abbreviated in your presentation, I would really greatly appreciate that.
Sure. So the only thing I'll say is we submitted on November 3rd. These last 2 months now, what they'll do is engage in negotiation with the states. So we don't really have a final thing yet because we were told to give a hypothetical $200 million budget. No state's going to get $200 million. It's going to be something less or something more. And then we have to rework all that stuff. So by December 31st, hopefully that is all determined. So now Commissioner Langfeld is going to tell you about the big 5 initiatives you were going to do.
Good morning. I appreciate the opportunity to be here today. I feel like the fire drill was a good example that we planned for this this application response. But let me walk you through a little bit of our process. As Dr. Stack mentioned, the House Resolution 1 was passed July the 4th. There was almost 3 months of speculation before the notice of funding opportunity dropped. In that interim, we wanted to solicit as many or engage as many stakeholders across the state as we could. Some of you may have been around, a decade ago when we did this thing called State Innovation Model work. And we had months and months to actually engage people and meet and sit around the table and talk and develop that. In this case, we had about 6 weeks. So we did send out, Dr. Stack submitted an opportunity for people to respond. We received well over 50 responses from all stakeholders across the state. I think including all emails, et cetera, close to 100. And and we, in fact, there's some examples I'll show in just a minute, and then we began to digest those, distill them, look for common themes around what had been submitted. We also, at the end, when we submitted the application, went back and got letters of support from many of those organizations as well. And I'm not going to go through this in detail. You'll have the slide, but it lists many of the organizations that were engaged in this process as we went through it. As we began to understand some of the common themes that we heard and coalesce around some of the common needs and opportunities, we coalesced around 5 areas. And these won't really be surprising to you. These are things that we've talked about, but how do we think differently about them? And you see them listed here: maternal health, behavioral health, substance use disorder, oral health, how we think about our trauma and EMS infrastructure and system, and then chronic disease as a general category. And then more specifically, I want to take just a few minutes to kind of walk you through what we call our 5 core vertical opportunities as we approach and prioritize where we want to focus with communities. Number 1, and I'll just they're not prioritized as far as numbers, but the first one is what we call rural community hubs for chronic care innovation. One of the thoughts was, well, we have multiple chronic diseases in the state. Let's pick 4 or 5 of them and let's focus on that. The reality is, though, that I'm not sure we've done the best job we can in any one single disease, and we know that most chronic disease has comorbidity. And so what we chose to do was let's focus on one chronic disease as a place to begin and understand how we can model that and optimize that and use that as an example going forward. And so we chose to begin with obesity and diabetes as our place to begin for many of the obvious reasons I think most of you are aware of. So that was our focus around chronic disease. The second area was as you know, we have many maternity care deserts in our state, well documented. Over 50% of childbearing women are in maternity deserts, and we're unfortunately expected that may increase in severity if we see additional closures of hospitals. So we really felt like this was an area we wanted to focus on. And we're titling this Powering Maternal and Infant Health. And POWER is an acronym. We like to use acronyms to kind of describe some of the things we're doing. The POWER stands for People Who Work for Engagement and Resilience. And this concept really looks at not just prenatal and through the continuum of prenatal and postnatal care, but also how we think about the infant care and mother-infant bond. And so, what does it look like? How do we think about expanding hands? How do we think about using community health workers and doulas and actually creating a team around the mother and infant partnership? The third area is around behavioral and substance use disorder. There are obvious needs in our state for this. We coalesced around the EMPATH. EMPATH is an acronym that stands for Emergency Psychiatric Assessment, Treatment, and Healing. It is an evidence-based model that already exists. It exists in about 20 states today, but the current program is run through the University of Kentucky. But EMPATH is really how do we deal with acute crisis intervention and then get people on the right path. It is the core of this area of focus, but one of the things we've done in our application is not just think about acute crisis intervention, but how do we think about the continuum from acute crisis intervention to resilience and living effectively in the community. So that's our third area that we chose to focus on. Oral health, I mentioned, we call our oral health initiative Rooted in Health. And as we think about dental care, we know we have lots of gaps in delivery system. We know we have lots of access issues. So how do we think about workforce? As Dr. Stack mentioned, one of the areas is what does our workforce look like? How do we use technology and innovation to fill some gaps? How do we think about increasing hygienist training? How do we think about using mobile vans? How do we think about using telehealth? All those technology functions in responding to a critical need that we know exists in our state. The last one is integrated, what we call crisis to care, integrated EMS and trauma response. We know that in our local community level, we have somewhat of a patchwork of emergency responses that many times function in disconnected ways sometimes. So how do we think about creating a way we can create some more connectedness? How do we, and response at the local level, things like treatment in place, and then also how's that connected to our trauma acute care infrastructure as well. So now on this page you'll see that one of the things in our application, we also wanted to make sure we connected these initiatives with some of the high-level objectives that CMS identified. So that's what you see here, whether it's making rural America healthy again, or tech innovation, or sustainability, workforce development. Actually, the foundation of all of the work we've done really is built on a foundation of how we think about sustainability. This is not meant to be a one-time grant for 5 years or a project for 5 years. This is meant to be how do we think and use this as an opportunity to create a blueprint and a roadmap for moving forward and continually improving and building on what we have.
And just as he said, there's 5 strategic goals. Every one of the 5 is represented there. There's 9 allowable uses of funds, except for the paying for provider care, which they really diminished. All of them should be represented over there on the right, many of them numerous times. So this is intentional so that the reviewers see that we're tying our proposed work to their grant opportunity. And then this is the last one.
Yes, last slide.
And this is the last slide, and then we'll go to the questions. So we are now in the period where they are reviewing and scoring these. Then they're going to engage with us. They've said they anticipate Thanksgiving to the end of the year. They're going to be in active negotiation with the states. And then what we'll find is hopefully December 31st, they'll tell us what we get. You also have in your packet just a short 2-page letter. For those interested, it has at the top of it some statistics about the rural nature of our state. On the back, it does mention as a paragraph the emphasis on sustainability. And again, these are things that CMS has said repeatedly, verbally. One thing that when I got interrupted by the fire alarm, I was going to mention was, and I've said it before, one of the really unique things about this is they have said if we don't fulfill things to their satisfaction, they may recover funds. This is different than usual. If you use federal funds for unallowable reasons, they can recover funds in any grant. This is not saying unallowable. This is you did the stuff you said you would. You maybe didn't achieve the performance you had hoped. This is unique. This is clawing back money you may have already spent. That's a real risk that has caused a number of states, I would say most, to not make policy commitments because the legislative regulatory process does not lend itself towards a 13-month guarantee of success. And you could have really, you got points, you got money based on those points, and then they claw it back. And if you don't deliver it the way they like it, you'd have to pay money back after you've maybe already spent it. So most states had just said, we're not going to attend to that. And CMS itself has said repeatedly, do not try just to maximize points. Propose things you think you can actually deliver because we're going to hold you to task for delivering what you said you can deliver. So again, that's important when you filter in, why did we pick the things we did? Because they should be helpful to rural Kentucky and rural Kentuckians, but they should also be things we hope we have partners in the state that can help us deliver it. And I think we're to your questions now.
All right. Thank you for your presentation. Senator Meredith?
Thank you, Madam Chair, and thank you, Dr. Langfeld and Dr. Stack for your presentation. This is not meant a criticism of you two gentlemen. I think you did the very best that you could do, but I'm bitterly disappointed in where this is going. I'm reminded of the quote from former State Senator Dr. Ralph Alvarado when he said, you don't think about building a sunroom in your house when the foundation of the house is crumbling, and that's what I see. I don't see anything here that's truly transformational for rural health care. I think it addresses some of the issues, and use a medical analogy. I think we're treating symptoms without curing the disease. The immediate reaction to H.R. 1 was that 35 hospitals could close in rural Kentucky, and that's half of our rural hospitals. This is not going to save them. It's not going to help. This is not going to save the rural healthcare delivery system. And again, no criticism of you guys. I think it's a typical federal program with as many handcuffs as they placed on you. I think you did the best you could do. But if anybody thinks this is going to be truly impactful and really going to change the tide for rural healthcare, I'm sorry, it's just not going to do it. So maybe it falls upon us with the Medicaid program to do something different. But we got a crisis that continue to be ignored. And again, commend you guys for the job that you did in getting this on a timely basis. But it's not going to save rural healthcare.
Senator Berg?
Thank you, Madam Chairwoman. Thank you for your presentation. First, I would like to say that I totally agree with Senator Meredith that this program that we're dealing with today is not going to do anything to address the long-term needs of healthcare delivery. But within the confines that we've been given, I think you've chosen excellent parameters. I'm really very happy with each and every one of them. My question is, what are we going to do as a state to document success? How are we going to track this so that we can show unequivocally that improving access to good oral health for rural Americans actually decreases cardiac disease? I mean, what parameters do we have?
So Dr. Langfeld's been really intentional about this. So there's, I'm sorry, I'll steal your thunder here. There's lagging indicators, like you look back over 2-3 years and say, what did you accomplish? And there's leading indicators, ones where you say, what's happening right now and how do we change what we're doing in the moment? And Dr. Langfield may expand on this, but there's an intentional approach to do both of those. But and I actually agree with the two of you. This is clearly not the Rural Hospital Stabilization Fund. This is not what Congress seemed to convey they were doing. It's not what happened. What they did was a different fund. Now, had we not had H.R. 1 taking $1 trillion out of the healthcare system, this on top of that could have helped, but it's certainly not going to plug the crater that's left by H.R. 1. But where I do want to give a little bit of cautious optimism, we don't have the money to do some of these things now, and here's where it could help. That empath unit that's operated at Eastern State works. It has helped people get into care who previously were going into an ER and languishing in an ER and not getting appropriate behavioral health care. It works. UK and Eastern State together have shown it works. It can be economically sustainable in the current reimbursement world. If we can put those regionally throughout the state, that will help Kentuckians. If we can get more hygienists and find a way for dentists to supervise them at a distance so that people can just get their teeth cleaned and have it recognized that they have a need, doesn't guarantee they'll have the way to get into care. But that's the first part, is recognizing there's a problem and preventing the disease from happening. The maternal health, this is an initiative that Medicaid and public health have already been working on to try to find a way to use existing payment methodologies to build a team around the mother and their unborn child for that year before birth and the year after birth to try to improve that whole continuum. They were already working on it, but now we have the means to expand it and really try to turbocharge it. So I agree with both of you, Senators, that this does not fix the problem of potentially numerous hospitals closing the state or service lines being shut down, but it does offer the opportunity for some really meaningful improvement in things we otherwise would not have the resources to do. So I both agree and offer an additional perspective.
Yeah, thank you for those comments. I'm reminded that when you think of something that should be transformative, how we think innovatively, I think one of the things we always need to think about is it different? I think you've referenced that a little bit. What's different than what we've done in the past? And so part of it is we need to remember what, if anything, we have done in the past. I'm reminded of the famous quote, those who fail to learn from history are doomed to repeat it, right? So I think of two things when I think about transformation or innovation and or improvement, which is what we're ultimately here to do. One is, Deming said, work smarter, not harder. And two, as Steve Jobs said, think differently. So what does that look like in our world today? As I think about our local communities, I've had the privilege of being in many communities around the state and talking with people, talking with organizations. I don't think I've ever heard any organization or individual say, we're just not doing anything. I think that we're doing a lot of good things, and I think we're doing a lot of things very well. But I think we're also doing a lot of things just not together. And so sometimes we have to begin with some foundational things of how we can work smarter, not harder. So part of the foundation of what we've written to and are attempting to really engender some activity around is how do we think about local communities and how we get them to work more collectively together. And I'll give you some examples of that. Every not-for-profit hospital, as you know, does what? A community needs assessment. All of our local health departments do a community needs assessment. In the Department of Public Health, we do the State Health Improvement Plan. Almost every organization does what? They usually do a strategic plan. What are all of those things intended to do? They're intended to identify what our priorities are and what we want to focus on. And there may be input across sectors from multiple organizations across the community. I think what often does not happen is after the fact, after we identify independently those priorities as organizations, do we actually come together and say, we identified these priorities. What priorities did you identify? How do we work together on these priorities specifically? And then how are we going to measure success, which is what you said. So I think we can do a better job of working and having collective action and therefore collective impact. The second thing relative to Senator Meredith and your comments about how do we think about measuring success. One of the things that happens, Senator Meredith, I don't know if you, I apologize. You and I had a conversation really a few years ago. I was sitting in your office and talking about why we need more data. And you made a comment to me is, we have lots of data. What are we doing with it? And that was a profound question to me. Actually, I didn't have a good answer at that time and because I think we do. We are engulfed in a lot of data and information, thinking about how we measure things. I Googled healthcare quality metrics one time. I got 192 million results in 0.4 seconds. You know, if you look at measuring quality, there was one study that showed across 20 federal agencies there were over 1,300 metrics. So we measure a lot of things. We're very thoughtful about that. But one of our challenges is, I think we in healthcare tend to be stuck in a backward-looking way. And I use this example. Think about trying to get to your destination, and the only thing you have available to do is to look through your rearview mirror. How successful are you going to be? Now, rearview mirrors are important. We should not get rid of your rearview mirrors for safety, et cetera. There are lots of good reasons for that. But how do we think differently about how we're using the data? The lagging indicators that Dr. Stack mentioned. What are examples of lagging indicators? HEDIS indicators. HEDIS metrics are lagging indicators. You know, we want to get perfect on our metrics. So we look back a year. We look back 2 years. We want to make sure all the data's there. Important to do, but they're not actionable. So as we move forward, how do we think differently about the data we're going to use? And I think we have in other industries lots of great examples. We you know, not just, I'm sorry, I'll speed it up. Let me use two quick examples. You know,
We really need to move.
Yeah.
We got to wrap it up.
Yeah, Ford
We
and
still have one more question.
Ford and Toyota, right? What do? They say, we're here, current state, where do we need to get to? They have rapid cycle feedback. How do we think differently about our data and getting rapid cycle feedback to analyze and course correct? And that's where the leading indicators come in play. So I'll leave it at that.
Okay.
We could talk about this for a long time. My apologies.
Senator Douglas. Senator Douglas.
Thank you, Madam Chair, and I actually do have a question, and I'll make this fast.
Yeah.
I really do appreciate the presentation this morning. Since we truly don't necessarily always talk about it in public, but we know that our object is to improve our healthcare outcomes. That's really what we're talking about. And since we realistically know that 60 to 70% of our patient health outcomes have nothing to do with the healthcare system, and I think you all will agree with that. My question is, how do these proposals motivate the clients, that is, those who are receiving the health care, to participate to a greater extent in their baseline health care, which is one of the huge problems that we're facing? Thank you, Madam Chair.
So I'll take this, and I'll just say I didn't touch on two of the five. So one is the chronic disease prevention, which is the one we propose to have the largest funding of the five. That's everything from how do we not become obese, and how do we stay more active so we don't become diabetic or have metabolic syndrome, to if we're at the risk of becoming diabetic, how do we maybe push that back, like diabetes prevention programs, to if we are diabetic, how do we manage that more effectively? So food is medicine, and which is healthy nutrition at the far end of that on the left, but is actually maybe prescription meals at the far right if you actually have disease. Getting people engaged in that continuum is really important. And so part of this we proposed, this was the yellow line that Dr. Langfield didn't touch on the that showed 5 things, is all the technology stuff, is how do we use consumer apps AI supported apps that help consumers to be more informed, more engaged in their own choices, their own actions, and then track and monitor, not Big Brother, but them track and monitor how are they engaging and improving their quality of life and well-being. For some of those other things, I didn't touch on the EMS part. It's come up at multiple committee hearings over years about the shortage of EMS workforce. We have a need to numerically increase the number of paramedics, medics, EMTs who are out there to support people, but we also have a need to help when they respond to someone's home. Do they necessarily have to be transported to a hospital? Can they maybe be cared for at the home? Can other problems be identified? So pairing a EMS worker with a community health worker, if they go to the home and find that in the home there are unmet needs, can a community health worker be plugged in with them to come and try to help meet them where they are and empower them and provide the encouragement to actually reduce their risk of falls, reduce their risk of other preventable problems? So I think, Senator Doug, again, this is a meaningful step, but an incomplete step. But there are throughout this numerous areas where there is the hope to try to empower the individual through information, empower them through encouragement, empower them through having access to things that are accessible to them, meaningfully to engage in that. Because I agree with you, without access to healthcare, people live sicker and die younger. That's very clear. But having access to healthcare does not make you healthy, right? So we need to find ways to improve lifestyle and environment if we want to improve population health. I wish I could sit here, the two of us, and say that we had the solution. Let me assure you we don't, because there's been a lot of smarter people who try to solve this for a long time, but we're sure going to try to make a meaningful contribution with as many stakeholders as we can.
Thank you. I appreciate your all's time, and I appreciate the presentation, and I appreciate your passion. Thank you very much. And next up on our agenda is Medicaid managed care delivery models. We have Tom Stevens, Catherine North, and Dr. Patel. If you all could make your way to the table. And introduce yourself for the record, please.
Hi, I'm Catherine North, Vice President of External Affairs for the Kentucky Association of Health Plans.
And I'm Tom Stevens. I am President of the Kentucky Association of Health Plans.
I'm Chirag Patel, CMO WellCare. CMO WellCare.
Okay, if you could please raise your right hand, and do you all swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Okay, that please proceed.
Okay.
Thank you, Madam Chair. We appreciate the opportunity to be here today. We'll start with, I guess it's our second slide, Catherine. There are 5 managed care plans in Kentucky: Humana, WellCare, Aetna, United Healthcare, and Passport. So what is managed care? Medicaid managed care is a system where the state contracts with private health insurance companies to provide health services to people enrolled in Medicaid. State pays an MCO a fixed monthly amount per enrollee called a capitation payment. The MCO pays for the member's health care, including doctor's visits, hospital care, prescriptions, and preventative care. The MCO takes on the financial risk. If care costs more than the capitation payment, the MCO covers the difference. Unlike in fee-for-service, MCOs pay for additional wraparound services, which we'll cover shortly. And I'll skip through some of this stuff. There are 41 states currently utilizing a Medicaid managed care model. Some of the benefits of managed care: promoting private competition to innovate, attract members, and improve health metrics; expanding consumer choice and personal responsibility; helping ensure predictability, stable budgeting for the Commonwealth; encouraging preventive care; prioritizing value-based care and outcomes; featuring strong contract standards. Notably, Kentucky has one of the nation's strictest medical loss ratios; and investing in social determinants of health, sometimes now called social drivers of health. So on value-added benefits, some examples of value-added benefits provided by MCOs: providing rewards and incentives for certain healthy behaviors like completing well child care visits, completing prenatal visits, diabetic screening, weight coaching, doula services, etc. Catherine.
Sure. And I will move quickly a little bit through this because I know time has been shortened. But this is a look at how the association representing all 5 MCOs have been able to collectively bring all MCOs together and think of what ways can we invest in improving access to care, improving the infrastructure to be able to really deep dive into these health organizations and programs. And so it's varied. There's urban and rural areas. It's been oral health, food insecurity, behavioral health and substance use disorder, social drivers of health, health emergency preparedness, and more. We really looked at kind of 5 ways that we could look at investing our dollars with improving health outcomes, increasing healthcare access that we know is so important, supporting those social determinants of health, and more. We have certainly invested in urban areas, but we've also been able to, especially being able to have all 5 MCOs on board, really look at in rural, in urban areas, we have a lot of resources where many organizations and companies come together and provide services or clinics or what it may be. That's not always the case in rural Kentucky. So this is just a quick snapshot of some of the ways we've been able to do some grant programming there, whether that's really addressing workforce shortages, remote area medical clinics, a remote dental van that goes to school districts. That was with the Ronald McDonald House. We've loved that. It's the first dental case manager of its kind. And then this is a snapshot, and I'll let you read that on your own. Most recently with that emergency preparedness, recently with the SNAP benefits, we were able to partner with Agriculture Commissioner Shell to provide this Kentucky food to families during the government shutdown. We've also been able to do prescriptive medicine boxes in hospitals. That's a pilot program in Russell County Hospital. This is a look at supporting our pregnant and parenting women suffering from SUD in Central Kentucky. And what I love about this as a mother myself is not only, this is with the Volunteers of America, not only are mothers being treated and supported, but their children are with them. So those children are supported too, and they still get to see their mom. We've invested in, we have workforce shortages. It is well known. So we've been able to do grant programming to support nurses and a master's in social work programming, and really having the intention of being able to attract, retain, and promote them to stay in the region. We want to educate them there, and we want to keep them in the region so that we can have an increased workforce with our healthcare.
Thanks, Catherine. So America's Health Rankings annual report is the longest running annual assessment of the nation's health on a state-by-state basis. It's the most recent edition. If you look back to 2014 and the implementation of Medicaid managed care in Kentucky, Kentucky has recently moved from 47th to 41st over that time frame. Now, that isn't where we want to be, but it does reflect measurable improvement. Next slide. So Kentucky has a value-based purchasing program aligning MCO's financial interests with quality. MCOs are rated at a 1% profit margin. 2% of revenue is withheld contingent on quality performance based on HEDIS measurement improvement. An MCO is not rated to be profitable without the achievement of quality measures. And if you look at the chart that's attached here, these reflect the new requirements for the 2026 contract. Dr. Pill, I think this might be an area where this would be something that you could comment upon.
Yeah, if you look at these quality metrics very carefully and you go back to what Dr. Stack said in the RHTP proposal, all of these align to the metrics and things that were written to. So there is significant alignment between the department and the MCOs on how to operationalize improved health outcomes, particularly on that previous slide that he presented, 1, 2, 3, and 4, all aligned to all the new metrics. So significant alignment between the MCOs and the department.
Thank you, Dr. Patel. Next slide. The National Committee on Quality Assurance, their most recent assessment of MCO quality rankings, Kentucky's MCOs are ranked in the top 10. Each of the MCOs is ranked in the top 10, just indicating that Kentucky is partnering with the best managed care companies.
This is a look at the network adequacy that we see within the Medicaid population here. MCO contracts with the state, they do establish requirements for network adequacy and include provisions to encourage continuous improvement in the access to care. And you'll see here, there are several clauses and amendments in the contract that really put the onus on the MCO to try to identify holes in the systems of where we may need more access to care, where are we with wait times, really having a care management program within the MCO to be able to analyze where we are in network adequacy. That varies by region. It varies by many different factors. And so they have a lot of teams on the ground to be able to analyze all of this data. So this looks like proactive identification and assessment of the member needs, the coordination of services across providers, and then evaluation of intervention impact. They have several tools, like what I was saying, in their arsenal to be able to do this. And this is really to be able to have a perspective of a voice in the area, of boots on the ground. What are Medicaid members experiencing when they need to get into a provider? How long are they waiting? How hard is it to get into a specialist, et cetera? So they're looking at the call center data. What are people saying? What are their worries as they're getting through the call centers? They have member outreach campaigns that come from the MCOs out, an analysis of the grievance and appeal data for trends, the partnership with DMS and the value-based program that not only emphasizes the MCO metrics, but it aligns provider agreements with the state's requirements and expectations. You want all stakeholders, all parties involved to try to have the best performance in that. Integration of social determinants of health into those conversations through that health risk assessment is really important too. Call center, interactive voice recording, case management, engagement, and more. Another great thing that MCOs can have is they can screen for levers outside of that clinical setting. They're screening for other needs that a Medicaid member may need to get that access to care. Oftentimes kind of that first step. So that's going to look like housing, food insecurity, maybe transportation. What are ways that MCO members need to be stabilized first before they can even get to the doctor? There are some guardrails as well when it comes to network adequacy. Per the contract, MCOs, and just in a likelihood of how this operates, as you know yourself, MCOs cannot control the appointment availability or daily scheduling practices of contracted providers. They incorporate all relevant regulatory requirements into their contracts, and that includes the network adequacy standards and the timeliness. This is also in the contract. Each MCO is utilizing secret shoppers to assess provider compliance with scheduling and access standards. So they're having people pretend they're Medicaid members. How long is it taking to get through? How long are wait times? How long am I in an appointment? How long is it to get, through to that specialist, as so often we need in a Medicaid population? I do want to note that I myself have issues with getting into a specialty provider. I myself have had to wait weeks and called every person I know to get into this one provider. I've spoken to some of you, and I know that some of you have had some of that as well. And even if they're a dear friend of yours, getting into a provider is not specific to Medicaid. This is an industry-wide. No matter what insurance modality you may have, network adequacy is just challenging right now. That's because of some of these factors. We have provider shortages that we know about. We were speaking about how we're trying to address that. High demand for specialty services and high no-show rates really do complicate appointment scheduling. That goes back to some of the other holistic ways MCOs can help. How do we get people get to this appointment so that we can get these appointments in? But there are moving holes here that should just be noted that complicate a network adequacy problem. Too, it is difficult to find specialist providers who accept Medicaid sometimes. That is oftentimes a real reality. This is a look at where Kentucky State Medicaid dollar goes. We've broken this into sections so you can see with the medical loss ratio, that MLR, but looking at the dollar, you'll see that the MLR is 93% of the dollar. That's going into pharmacy, professional services, outpatient and inpatient services, and then FCHQs in our rural health centers. 5% of that is the administration. And so that looks like entire teams to support provider services, to support member services. Special investigations units are very important with fraud, waste, and abuse in Medicaid. Compliance departments, quality departments. You'll see 1% quality measure, that's clinical care in the quality department, and then a 1% margin. So an MCO is working with a 1% margin on the dollar for all of this. And Dr. Patel could maybe offer some more insight into the specifics of retail pharmacy versus professional services and things like that.
Yeah, I think retail pharmacy is continuing to grow year over year in our state and in other states. I think it's important for us to use evidence-based clinical policy to design what we do going forward around specialty meds, perhaps GLPs and brand name meds. I think using generics are widely accepted. And then in professional cost, I think we have seen BH providers and BH utilization go up year over year. And how we manage that going forward to get the right outcomes for the dollar that's spent, there is a little bit of a mismatch that we need to continue to address.
Thanks.
Excuse me. So in preface to this slide, KHP is in the process of updating its last report on savings of managed care, specifically compared to a fee-for-service model. The last study that we had showed a $200 to $300 million Kentucky-specific savings on an annualized basis, and a much larger total spend savings related to that. We do anticipate having that before the legislative session begins, so we look forward to being able to share that with the committee. Specifically to this slide, one of the requests that we were given by the committee was to suggest additional possible savings that we could generate in Medicaid working with managed care. So these are some of the examples that were submitted by our membership. And I can go through some of these here, and I'm sure there'll be an opportunity maybe with questions later. Comparing services provided in Kentucky against other states. Does Kentucky have the right mixture of service covered? Carving out long-term support services into managed care. Changing outpatient reimbursement from percent of billed charges to a fixed fee. Changing inpatient reimbursement from an MSDRG to an APR-DRG model. Amending Medicaid legislation passed in recent years. Considering funding sources to expedite fraud, waste, and abuse investigations and eliminate waste in the system faster. Mandating Medicaid reimbursement not exceed 100% of Medicare reimbursement. Encouraging site-neutral payments and promoting proper credentialing practices, particularly in SUD. I don't know, Dr. Pell, if there were any specific issues there that you wanted to comment on, but
In the interest of time, we'll wait for questions at the end.
these are some headlines from recent Kentucky fraud cases. You got the examples on the right there. One of the organizations that we work with is the National Healthcare Anti-Fraud Association. They publish some different metrics, and they estimate a 3 to 10% total health spending is fraud. So in Kentucky, obviously, that's a huge number, in excess of $500 million. Every dollar lost is a dollar not spent on families, and so it justifies many of the different activities that the MCOs provide.
This is a look at how MCOs really can be a partner in this for program integrity. These are some things that align MCOs, the cabinet, Kentuckians, to all have this great oversight and really goal of having good program integrity in the Medicaid system. One is there are aligned incentives. There are fixed actuarially sound rates that make prevention a financial priority. Real-time monitoring. It is not uncommon for an MCO to be the first line of defense, the first one to notice fraudulent behavior and notify the cabinet. So they're looking at data analytics and the special investigative units that we were talking about that are on their teams. They're flagging billing and provider irregularities. Medical necessity. Plans review and verify that services are in fact appropriate and documented. Provider oversight, credentialing and audits ensure qualified providers are paid. And then collaboration. MCOs coordinate closely with the state on investigations and safeguards. This is a look at where MCOs fall within their perimeters based on the contract. It is important to note that MCOs have no control over who is enrolled. They do not pick who is enrolled. They are told who is enrolled. So the department, this is part of the contract, shall have that exclusive right to an individual's eligibility. It shall be final, and it is not subject to review or appeal by the contractor. And then there are recoupments in place for this. So, if an enrollee appears on that enrollee listing report but is determined ineligible, there are monthly reconciliations that happen, and those payments can be recouped from MCOs.
As Catherine said, MCOs are really the first line of defense in fraud, waste, and abuse. MCOs detect and prevent issues before taxpayer dollars are lost. Continuous monitoring catches outlier providers and questionable claims in real time. MCO oversight confirms services are medically necessary and properly supported. And it's important that states have strong controls to prevent missing documentation or unqualified staff. Kentucky's MCO model helps avoid those risks while improving care quality. And if you can, I know it's kind of small to see on here, but we do have a chart that indicates a number of common Medicaid fraud areas. So some of these I can read off. So billing for unnecessary services, billing for services that aren't provided, unbundling, card sharing, collusion, drug diversion, kickbacks, etc. These are all examples of things that we've seen just straight out of the newspaper. With that, we tried to move through this fairly quickly, Chairwoman, but we can probably go ahead and conclude our our formal remarks now, subject to your questions.
Sure, that sounds great. And yeah, I'm sure the committee, if they need to expound upon something, they will ask you that. I just have one question that you can tell me how this works. On page 3, you talked about how the MCO pays for prescriptions. I thought we went to a single PBM. So does the MCO pay for prescriptions, or did we go to the single PBM? How does that work?
There is a single PBM, PDL, but the dollars are coming from the MCOs, right? So it flows through the PBM, PDL. They decide which prescriptions, but the dollar comes through as a pass-through from the MCOs.
It's a pass-through.
Yeah.
Okay, thank you. All right, Senator Meredith.
Thank you, Madam Chair, and thank you all for your presentation. But I'll admit it, sometimes I think we live in alternate universes because what you talk about and what I see in real life, particularly in rural Kentucky, is just not there. And I'm going to read you a quote from the Journal of Appalachian Health from August 2023. It says, addressing the extreme poverty and associated unmet social needs in Kentucky's rural Appalachian counties, and I think this applies to all rural counties, may be essential to seeing any real progress in health outcomes. You note on your slide you spent $4.3 million on targeted healthcare grants, again, to help address social drivers of health. We know that's 60 to 75% of healthcare issues are based on that. That represents 0.0002% of the total Medicaid budget. So I don't know that we're making a fair distribution of Medicaid dollars to address those social determinants of health. Maybe the specific question I have for you, you heard my comments earlier for Dr. Stack about the crisis at rural health care. What are y'all doing specifically to address that?
Well, the 4.3 number was from the association. So that's in addition to what each MCO is providing.
How much do you think that is?
I don't know.
I don't know, Senator Meredith, but we could certainly get you a number and bring that back.
Well, I know I'm kind of getting away from my question, but another question I've had is how do you decide which areas you're going to focus upon? I would think a priority should be given to areas where we can truly reduce the cost of health care. As an example, one of the number one killers in Kentucky, particularly in rural communities, is trauma-related care. Mm-hmm. We have an appropriation request, have for years, for about $1 million to establish a statewide trauma network. That would reduce cost of health care, particularly for Medicaid program. Why should that be an expense of our legislature rather than the MCOs? Why don't you all fund that portion of the program? Another example is colon cancer screening. They made a request to double their appropriation from us from $500,000 to $1 million a year. Why wouldn't you all fund that, since it helps reduce healthcare costs, reduce Medicaid costs, rather than come to the General Assembly for that?
Do you mind if I take that question?
No.
Respectfully, sir, we'll start with the first comment and then move backwards, if you don't mind. So in terms of colorectal cancer screening, we actually do fund colorectal cancer screening through FIT Test and Cologuard. We have sent tens of thousands of them out for free to our members, and WellCare has the most rural members of all the MCOs, even though we all share that rural membership. we also have televisits and phone calls to help the member fill out the Cologuard and FIT test, because we also know to improve health outcomes in our rural areas, you can have more docs, you can have more hospitals, but until you improve health literacy, right, you cannot have these members really address their own health care till that literacy piece moves up. And so us helping them fill out these Cologuard, FIT tests, mammogram, vaccines, so on and so forth, you can't actually improve the healthcare. And so we do fulfill that need, right? Could it be more? Sure. What the right number is, we can have a discussion about that. In terms of going back to what are we doing as an MCO cohort, we have discussions with the department quite frequently about how do we create an environment to attract more younger primary care providers who are willing to stay in these communities and serve these members, right? That is where the issue is. We don't have enough primary care providers anchoring in a community, then bringing a pulmonologist, a cardiologist, a nephrologist, and a general surgeon. That's the 5 that you need anchoring near a hospital to really provide community-based rural transformative care. There's many states who have done this. Maybe you have a backstop of salary guarantee for 2 years while they build that practice. Maybe you subsidize an EHR that connects all 5 providers. But that's how you build what we would call a medical community for a rural area, right? Near a hospital that's a critical access hospital. That's real innovation. That's transformation. And then you put support services to improve health literacy, because without improving literacy, all you're doing is top-down. Nobody likes top-down care. Respectfully, sir.
Well, respectfully, you're talking in theory, but in terms of practical application, that's not working.
It's
And I
not
speak
working.
from experience as well. If you want to get physicians in rural communities, they've got to be paid fairly. And I've asked a question of you folks and the cabinet as well. Why would anybody choose to practice in a rural community knowing you can make 25, 30% less than your urban counterparts with a patient population that's more difficult, less compliant? Why would you do that?
Well, respectfully, sir, if you are subsidized by a large organization, you're on an RVU model and not on a cash claims model, you would be paying 75th percentile of MGMA, and docs will come. But if you are getting paid cash claims, there's no chance anybody will come.
Well, I would disagree, because when I was a hospital CEO, I grew my medical staff from 7 doctors to 34, and I was able to do it because I guaranteed them they would at least make the median for their specialty if they would come to rural Kentucky. Physicians will come to rural Kentucky if they're paid fairly. But again, I'll go back to my first question for you is, what are you doing to address this immediate crisis of rural health care in Kentucky?
Our role is to partner with the department to move forward in a collaborative fashion and follow their lead.
I've been in this field for 50 years, and I've heard the same line for 50 years. We're not moving the needle. We've got a crisis that's going to be a biblical proportion. If we, in fact, do lose 35 hospitals, it's going to collapse the rural healthcare delivery system, but also collapse our rural economy, which in turn is going to reverberate throughout our state. I heard Congressman Andy Barr talk at a function recently, and I was very pleased that the first time I heard a politician talk about payer mix and how important that was. If we, in fact, lose 35 hospitals, those patients are going to go someplace. They're going to go to the urban areas, and that payer mix is going to decline for our urban facilities as well. And the same crisis we're seeing in rural Kentucky, we're going to see in urban Kentucky at some point in time. So I'm still looking for some immediate strategies. How are we going to address this crisis? And I just don't see it being offered.
Senator Carroll?
Thank you, Madam Chair, and thank you all for being here. And this presentation is one I dread every year because my blood pressure always goes up. And the reason that I have some of my blood pressure problems is dealing with MCOs. The facade that you all portray is not reality within this Commonwealth, and it's frustrating and it's insulting to hear it year after year after year. You all do not partner with your providers. You are a deterrent to providers opening up and expanding within this Commonwealth. You talked about the fraud. I think Auditor Ball has a disagreement with your comments about you preventing fraud, and I'm sure you all have read that report. What is your response to the auditor's finding with the $800 million? And I know not all of that Kentucky, but I think the figure looking at Kentucky was around $600 million.
Well, I think that she raised some good points of interest in that report of the realities of the public health emergency. It was truly an unprecedented time. And when you look at it from a medical perspective of budget predictability, rates were retroactive in that moment, intentionally set because no one knew how many hospital utilizations there were going to be. Was everyone going to be at home doing telehealth? Were they going to be in hospitals? What was this going to look like? And so there are two parts to that. I'll start with the past. During that section of time, those have been paid. The rates were retroactive, and so they have been repaid based on the actuarial reconciliation during that time of those rates. Moving forward, there are monthly reconciliations in place. There are recoupments available that DMS can always do every month with the recoupments. And then you have the one big beautiful bill, what's coming down from HR 1. You have redeterminations that are going to be happening every 6 months. But additionally, CMS just put out a guidance last week making it a priority for states to redetermine. They're going to send a unique file down, CMS's, to the states where they're going to cross-compare. They want CMS and the state's data to be cross-compared for redeterminations, and then that information will be sent to the MCOs. It will be on the MCOs to reach the member to confirm their residency and to confirm that they are still a valid, eligible enrollee. And then there are tons of ways that they can do that versus if they reach them, if they don't reach them, it has to be ample time. They can't just send out a notice, hey, I need to know your eligibility, and in 24 hours you're done. It has to be reasonable. It's known that this is a transient population. This population moves a lot. It does now. It really did during COVID. And so there were measures in place to know. Most importantly, we have to provide the access to the care, and then we'll retroactively fit that in. And rates were repaid in that. And so moving forward, there's going to be more continuous oversight and checks in that. Does that?
So how much of the fraud that was reported is the DMS recouping from MCOs?
Those rates were repaid at years ago. Do you want to?
Yeah, I mean, Senator, I don't know that we know that there's actually any fraud in there. We know that they've identified people that had dual residency, but we don't know what of those were correct in Kentucky and what could have been someplace else.
Okay. Thank you, Madam Chair.
So I know you all receive like a capitation rate per member, and sometimes that rate covers the care for that particular member, and sometimes it's too low to cover that care for that particular member. And sometimes there's a member that never accesses care, and so you just collect that capitation rate for that member that never accesses care. Can you provide for the committee that ratio of, that capitation rate for who goes over, who goes under, and then who never utilizes that? Do you all have that broken down for this committee?
I believe so. We may need to ask Commissioner Lee or Secretary Stack, but so the capitation rate is set based on a previous year's claims, divided by the member, divided by how many members there are, divided by the 12 months. And so this is one of the perks of having an MCO. It is a single-sided one risk corridor. There's a capitation rate set by the state, and that is deeming we think it's going to cost this much money for a service. So if an MCO pays for the service and it costs more than that capitation rate, the MCOs eat it. It's lost money.
Right.
If it's less, they have to pay it back to the state. So there are mechanisms in place from the third party actuary too, where the capitation rates are set very conservatively. So there's not there's not excess, and then if there is excess, it's paid back.
Okay, so like if client A never accesses care, then you pay that back. Is that what you're saying?
Yeah.
So that's a great question. We don't do it at the member level. It's done at a panel level. So
Okay.
for example, if I had a member that went in for sepsis and cost $500,000, but I had 10 members who didn't access health care, the money of the 10 who didn't access the health care would subsidize to pay the $500,000, right?
For the sepsis.
That's
Okay.
correct.
Okay. Okay. Thank you. I have Ms. Schuster.
I agree with Senator Carroll. I don't think that the MCOs partner with their providers. And I want to talk about behavioral health because that's what I know best. Our providers are paid. There's very little, if any, negotiation with providers, maybe with psychiatry, but certainly not with anybody else. We're paid 80% of the fee schedule that's posted by DMS. What's that all about? And then there's no network adequacy. And I'm a little bit concerned if you all are doing the secret shopper surveys. Is that what I understood from your presentation, that you all are actually doing those secret shopper surveys?
My understanding is there's a requirement in the contract that is a service that's provided. But I don't believe that it's actually done by the companies. It's outsourced to an individual or a vendor that does that service.
And where are those results posted? Because I sure as hell would like to see them. I'm sorry, I sure as heck would like to see them. Because I can tell you that if I sat at home and started calling the providers that are listed in your networks, there are tons of providers in there that don't know that they're listed in your network, that haven't ever been in your network, that are retired, that are dead. I want to know where the results of the secret shopper surveys are. And the last I saw in the CHFS was 2023, and it was for pediatrics. So what I want to know is who's enforcing the network adequacy? I mean, you all are responsible for saying that there are providers out there, and there are not providers out there in behavioral health.
Can you give us a concrete example? Because we actually work as a group of MCOs to do credentialing and to look at network adequacy. So if you have a concrete example, we'd be glad to address that particular example. And then back to some of your other commentary, what was the question that we could kindly address for you, ma'am?
I want to know about the secret shoppers.
We will get that information for you.
But you had it in your slide, so you're touting that you're using the secret shopper to confirm network adequacy. Is that correct?
To confirm availability of appointments, availability of services, proper services rendered. It's to understand if providers are doing what they say they're doing.
How do we find out if the MCOs are doing what you say you're doing?
I'm here to answer questions, ma'am. Do you have a question for me?
I've had lots of questions for you at the BH TAC, Dr. Patel, about the number of audits,
Yes.
the number of clawbacks, the harassment that providers have when you know who the poor performing providers are, and you're going after everyone.
So, ma'am, respectfully, we work within the construct of the contract and the rules that are dictated. When we do see behavior that's untoward and questionable within the contract, we do bring it to our state representatives, and then we do work with the provider to gather data around said clinical practice. And when said clinical practice is not meeting clinical standards, or perhaps not meeting standards that is above board, we do report it to the state, and then we take actions that are within the purview of the contract.
I would just say that Kentuckians who are looking for behavioral health services that have Medicaid coverage are not getting the care that they need, and that's a great concern to me. Thank you.
Representative Bowling.
Thank you, Chair Adams. And I'm actually following up on a question that you asked, but just to clarify for me. On the capitation rate, you said that was the previous year's claims divided by the members.
It's not the previous year, maybe 2 years.
Is it?
Is
That claims or paid claims?
That's a good question, Representative Bowling. Let us check. I want to say that that's going to be paid claims, but we need to confirm that.
Okay.
I apologize.
Yeah, no problem, because if it's paid claims and you use that data, the only way that you can get your 5% administrative, 1% margin, 1% quality is to either increase the membership or decrease the benefits. So that kind of gets to the heart of my question. Thank you.
Sure.
I have Dr. Petrie and then Senator Meredith.
I just want to follow up with a concrete example. And I was actually had a separate comment until I heard your all's most recent responses. I have a concern over the network adequacy, and I speak from the dental perspective as an orthodontist in East Kentucky who sees patients from west of Bowling Green, east to the Kentucky line in Prestonsburg and beyond. We have a severe shortage of dental providers, orthodontists, oral surgeons as well, specialty providers. I have a concern with recent events, and it is not with your MCO, but I have a concern that recently we have had a change with one of the administrators. That administrative change, moving Aetna to SkyGen, as you're aware, oral surgeons specifically, but most dental providers have had challenging experiences with SkyGen, and many are now no longer accepting patients that are now with Aetna. Unfortunately, from your all's data, Aetna still has a strong provider network. Why? Because the providers were moved straight to SkyGen without a discussion. And so SkyGen Aetna shows that they have a provider. Meanwhile, I can't refer a patient for oral surgery to anywhere but the university hospitals. In so doing, I have patients that have current need, oral surgery need specifically, that can't see someone for 6 to 8 months. Now, this is exacerbated by something that I'm not sure is clear, and that is that the foster children of Kentucky are all mandated to be on Aetna, which means one of our most challenged group of children are even more challenged because they now have no option other than the university hospitals. Now, it would be my hope that foster parents will make that effort to get a child from Far East Kentucky to Lexington or Louisville. But that is not happening. And we have children that are not receiving care because, as you point out, the state mandates which patients are with the MCO, but the MCOs mandate who the administrator is. So when the MCO chooses an administrator that practitioners will no longer work with, the child is hurt, the patient is hurt, and this very difficult population of the foster children are caught in limbo. And that is an extreme challenge for me.
So I will acknowledge 110% you're right. There is a dental desert almost everywhere. I believe that. It's almost at the same prevalence as our maternal health deserts. I think one of the things that the department has done to help at least upstream address that is to put some of the dental preventative care into the value-based program. Is that an answer? No, but it's a start. So that's the one piece. In terms of your direct issue, I agree. I think that type of behavior is something that we need to correct. That is not an acceptable type of behavior for any of the MCOs, and we will take that back through the association. I did handle a dental issue here just recently over the last couple of weeks for one of our members, and came to know this type of situation, even though we don't use SkyGen, but I will take it upon myself to make sure we address this.
Senator Berg, you have a question, comment? And I'm not Julie Rocky Adams.
No, you're not. Your voice changed. Thank you, sir. You know, listening to all these conversations and listening to this presentation and really thinking about where are we in this state and what are we doing, I think it comes down to, with your secret shoppers, your patients are happy. The patients that Medicaid serves in this state are doing okay. Your providers are miserable. Your providers are fighting you tooth and nail for every penny of reimbursement. And it's taking time, it's taking energy, and we're losing providers as a result because nobody wants to sit and knock their head against the wall 24 hours a day. And our frustration, honestly, is not just with you. It's not just with the MCO providers in this state. It is with the insurance industry, the health insurance industry as a whole. It is not helping the delivery of health care. And that, and to say people are satisfied, your providers are far, far from satisfied. So I don't know how to resolve this. I don't know how we come up with a system that serves both the needs of the patients and the needs of the people that we are paying in this state to take care of them. But what we have isn't it. Thank you.
Representative Mosier.
Thank you, Madam Chair. Thanks for this presentation. This is so much information, and it's something that we obviously think about a lot. We have this committee here to specifically talk about Medicaid, and the MCOs are the deliverers of that care. So I think I'm going to focus on and tag on to Senator Burke's question about how we treat providers. We had some bills last year that talked about contractual compliance, really, and how we treat providers. And one of those bills dealt with the waste, fraud, and abuse situation and the prepayment review. Can you walk us through what the prepayment review is and how those investigations work with providers to correct any mistakes that are being made, or I truly want to understand more about how that works, because it feels very punitive. And from my perspective in talking to providers, when there's some notation of impropriety, the information shuts down. They get no information. So if we can better understand how that works, I would appreciate it.
Representative Moser, are you particularly talking about in the BH space or in the medical space?
I think it's across the board. We're talking about determining waste or fraud. These are investigations that I understand are sent to the Attorney General's office.
Sure.
A year-long investigation ensues, and the providers get literally no information about what went wrong, and the payments shut down.
So let me walk you through kind of how this works for us. So let's say said provider let's use the BH space. It's very popular these days. We see some rendering of services that's beyond what's considered normal for said member. Then we see that it's across multiple members over a multitude of time. we have a program called Partnerships in Care. We do. It's a clinical program. It is not a prepayment program. We reach out to a provider to discuss what services are rendered, how you're rendering them, are you billing it appropriately? Often the provider doesn't have the understanding to bill it properly. We give them the opportunity to rebill it. Then we give them the opportunity to explain clinical services, how they're being done. Are they unbundling it by mistake? So there is a whole length of time of bidirectional dialogue that's framed clinically, not fiscally. Then we give them an opportunity to correct that behavior. If that behavior is not corrected, actually sometimes we see it go the other direction. It gets worse. And then in that time, we take it up through our compliance and legal channels. We try to work with the provider. And then if it's not rectified then it moves through a state process. Once it goes to a state process, we are not able to really communicate with the provider because it's in now the state's hands. And so there is a formal process which we follow. Now, we do have significant discussion with the provider, but let's be honest. Once we get to a point when these clinical discussions, the provider starts to shut down too. Because sometimes, not all the time, they are doing egregious behavior. And we have seen that particularly in some of the BH space around peer support, psychoed, which we've had to rein in through policy. And so this is our job, which is to work clinically, but to also make sure that the state dollar is being used wisely. And so we are always going to look like the bad guy, at least with the providers. And I work in rural Georgia, so I take Medicaid. My wife takes Medicaid. I understand the provider's plight. I would say that we all have room to step forward and be part of the solution. We're part of the problem, sure, but we're not the only part of the problem.
Okay, thank you. I mean, I appreciate that, and I appreciate that providers are given time to better understand billing practices and to correct their mistakes. But that hasn't always been the case, and I do understand the behavioral health piece of all of this. I know that the psychoeducation code has been wholly abused, and I'm not even sure that I think we need it. We have therapeutic models that could be used. And so, that's maybe a separate conversation. And I think that's one example of a pretty egregious, it was pretty rapidly increased as I don't know, maybe other CPT codes were not being utilized or paid. I don't know exactly the rationale. I think we can do a better job of credentialing providers and ensuring, especially around the IOP space where we really don't have any sort of CON or any control over who comes in except for credentialing. We need to make sure that the providers who are coming here are here to actually provide care and not just abuse our system. So, I may have more questions in the future, but thanks for that explanation.
Yes, ma'am.
Senator Carroll.
Thank you, Mr. Chairman. And I can get into an incident of an investigation that was conducted by the MCO. I'm not going to get into details, but turned over to the AG's office. The same incident with another provider had occurred a year further. This year earlier, the same MCO, they turned them over to the AG's office. That case was dropped. It was cleared. Same circumstances with the case I'm talking about. I'm talking about the MCO pursued with the AG's office. All of that was cleared up, and everything was justified. Everything was clear. Everything was done properly, and the MCO still refused to pay, and it's not paid to this date. And that's been over a year ago. That's a good example of what we get from MCOs. And Mr. Chairman, the question that was just asked about billed claims versus paid claims, Dr. Stack, do you know the answer to that? That is significant, and honestly, I've never thought about that before.
Senator Carroll, I just want to clarify. Are you talking about how the capitation rates are developed?
Yes, on what we actually pay. What is the amount that we do pay the MCOs?
Yeah, there are various factors that are taken into account, but we do look at paid claims and the trends from previous years, but there are other factors that are taken into play, and I can get all of those for you if you want. But I think the main question you want to answer is we do look at paid claims.
Very good. And from a general standpoint, and I asked this question several years ago, what are the other means of net profit that MCOs make through this whole process? And I want you to be creative in your thinking on any way that the MCOs generate funding off of the states through this MCO process other than the capitation rate.
We have the quality program, which now is a withhold. In other states, the quality programs are above and beyond, and they're not a withhold. In this state, that's the only way.
Okay. The interest from the funding that you all get every year, is that profit?
Can you repeat that question?
The interest from the capitation rate, you get a check from the state every year. You get a check from every state every year. And I'm sure that goes into accounts, and you all get interest off of that. Is that profit that an MCO makes?
I would have to defer that to our finance folks. That's I don't
That
know.
doesn't factor in the 1%, correct?
Yeah, and Senator Carroll, I mean, I do think the payments are on a monthly basis. I don't think it's on an annual basis. I don't think there's that much of a lag.
Okay,
But I do not
it
believe
is
that
monthly, or
factors.
I understood it was annual.
It's
I'll check back, Senator Carroll, and I'll confirm and get back with you.
Yeah, let's talk about it now. We're always checking back, and I'll get back with you, and that never happens. So let's see if we can answer that now. Commissioner,
we're gonna double check. I am pretty sure. I believe it is monthly, but we're gonna double check.
And we'll check. It's not annually. We don't cut $18 billion of checks at one time. I know that for
I
a
think
fact.
the principle's the same though. Is you're getting paid the capitated rate each month. So this point is that you're making money off the float of the money until you pay the claims. Correct? That's not indictment.
so
criticism.
there is an
It's
advantage to you all delaying payment of claims because you're drawing interest off of that money. Is that correct?
I wouldn't call it an advantage because claims don't just reset at the end of the year. Right? There's claims that go, like if somebody has a claim in December, we're still paying it on an ongoing basis.
But you're not paying interest on that claim that you're holding, and that's the point, is you've got a float that you're working with. And again, this is not a criticism, it's a business decision. Anybody would do it, a business practice. You make money off the float. Right?
I'd have to defer that to our finance folks.
Any business would. That's just common sense.
And the point is there is a systematic effort to avoid paying claims or at a minimum delay claims without justifiable reasons often. And that's from my experience, and that's from every provider that I talk to. It's the same story. And again, the administrative expense that this state puts on providers by having MCOs that you all put on providers is a significant cost to providers in this state, which is a deterrent to growth and expansion. And I'll leave it at that, Mr. Chairman. Thank you.
Thank you. Final question from Steve Shannon. We do have one request for public comment, and we'll move on to that next.
Yeah, I'll try to keep mine short. You talked about the increased cost associated with behavioral. I mean, I'm just a behavioral health guy. That's really what my focus is. How much of an increased cost is that in the big picture? Get some data on that. You also talked about some behavioral health providers. How many are those? I represent 12, and there's 14 mental health centers, and we are audited repeatedly, and we're not one of those bad providers. So can we get a number of what percent? Are you listening? Yeah, just checking. What percent of the overall spend is on behavioral health, and a breakdown by provider group? I acknowledge psychoed, right? I'm also going to tell you, polled CMHCs didn't do a lot of psychoed, right? I just don't like the broad category of behavioral health being identified. No one says physical health is a problem. It's a broad category. You break that down. Behavioral health, I want to know how that is spent, what's the diagnoses, because I think there's just some misinformation about behavioral health as the problem. I think we need to know what are the problems within it. Otherwise, we can't address those because it's just behavioral health.
Yeah, thank you, Mr. Shannon. Looking back, I know one particular slide on a presentation last year to A&R, we showed a 22% annualized trend over the last 3 years in outpatient behavioral health. You're going to ask me what the raw number was, and I don't have that in front of me, but I will present that number and get you the slide.
Okay. And the bulk of that, I think your commentary is very fair. We should not paint with the broad brush BH.
It's a spray painter. It's not a brush anymore.
Spray painter. But substance use disorder has been typically what we've identified as a place where there's been tremendous increase. And what's more problematic is it would be okay to have the increase in cost, but we're not seeing the outcomes to match. And I think that's where we're having some consternation. We would be willing to have these services, but we're not getting substance recovery outcomes. And that's problematic.
Yeah, and substance abuse is problematic.
100%.
It's not a one-time deal. I mean, many people I know relapse, they get treatment. It's not necessarily anything about the provider or just the individual. It's the nature of substance abuse. So you're going to see that.
I appreciate everybody's
You can
comments, and
anticipate
we
that.
need to move on. We can certainly do some follow-up later on if we need to, but I appreciate you all being available to us today. Appreciate your presentation. We do have one public comment. Mr. Lauder, if you will come forward. If you would, please introduce yourself for the record.
Thank you. I'm Mary Catherine DeLoder, representing the Kentucky Birth Coalition.
Appreciate you being here. You have 3 minutes.
Thank you. Thank you for still making time for this despite the earlier disruption in the meeting. In 2019, Kentucky began licensing certified professional midwives, which are maternity care providers for women with normal, healthy pregnancies. CPMs provide prenatal, labor and delivery, and postpartum care in community settings other than hospitals. As you know, about half of all Kentucky births are covered by Medicaid, and we have a shortage of providers, but certified professional midwives are not yet allowed to be Medicaid providers in Kentucky. The services they provide are covered because birth is covered, but the provider type is not. As a result, some women who want this care from a CPM forego their preferred option and choose a different provider instead who is covered. Some people find a way to pay for the licensed certified professional midwife out of pocket, often with great personal financial hardship. Or there are others who still opt for birthing without a licensed provider. And while some women may choose that, they shouldn't ever feel like they have to choose that to make this choice due to a financial hardship. CPMs have excellent outcomes helping women with low-risk pregnancies to stay healthy and to avoid unnecessary interventions. Medicaid already covers all aspects of pregnancy and birth, and CPMs need to be included as providers for Medicaid in Kentucky. There's been some legislation on this topic that has been in the past, and you will be seeing that again, and so I hope you'll consider supporting that in the future for those of you who are legislators. Thank you.
Thank you. Appreciate your comments. Just a couple announcements very quickly, then we will adjourn. Our next meeting is scheduled for December 10th at 11 a.m. It's on a Wednesday. And you should anticipate this will be a longer than the usual meeting. And inasmuch, we'll take a lunch break before returning to the meeting. So if you would, please be prepared. With that, any further comments? Seeing none, we stand adjourned. Thanks for everybody's participation.